Good evening, good evening, good evening.
Yeah. So we start, ready?
Yes, you have to start.
Yeah. So, very good evening. TTS, Thrissur talk series, that is I-square, immunization. So please mute others, Sidhir.
Please mute others. Please.
Unmute, sir.
Sir, unmute, sir. Harandesham, sir, please unmute.
Yeah, it is 15th series. On behalf of the IEP Thrissur and I2 series, I would like to welcome all of you. I welcome our active hyperdynamic president, Dr. Reddy Shantakumar, and also secretary, Dr. Sidhir Kumar, and also our chief guest, my teacher, and the great neurologist, pediatric neurologist from SAT, now KIMS, Dr. Kunju sir. And also I welcome Dr. Johnny Sebastian. I welcome Dr. Anju Deepak, president of IIP Infectious Disease Chapter. I also welcome VK Parvati Madam, HOD, retired past HOD of Medical College at Thrissur, Dr. Jayagumar, Dr. Rajagopal, and other senior members and dear IEP family members. Today we are likely to have a common topic, viral encephalitis syndrome, and also a popular great academician speaker, Dr. Mohammed Ghani. I think we can enjoy today's program. With this few welcome, I invited Dr. Reddy Shantakumar for her presidential address.
So good evening to all members. Welcome to our Thrissur IAP exclusive Thrissur talk series, which is based on infections and immunization. And today's program is on acute encephalitis syndrome by none other than our Professor Dr. Mohammed Kunju. And we are very happy that even the president of the IAP Thrissur Neurology Club is from Thrissur, Dr. Rajagopal. Welcome to all the seniors assembled today for the program. So in the good old days, we had only few terms like meningitis and encephalitis, and we'll think of adding some acyclovir if child is not well. But now that's not the situation. So many new terms have come which are really mind-boggling, like autoimmune NMDA encephalitis. To add to the mystery now, NMO, then MOGAD encephalitis, then is it multiple sclerosis, is it ADM? But today, indeed, our chapter is very privileged to have our illustrious speaker, Dr. Mohammed Kunju, who will unravel the whole mystery and will tell us how to differentiate between encephalitis and all these overlapping syndromes, with Dr. Anandakeshwan to chair, whose pet topic is neurology. So thank you, sir, for being amidst us, and thank you to all the senior IAP leaders too. Members, to update you all on what is going on in our Thrissur IAP, our last session was very interesting. It was the clouds, dark clouds in the COVIDian sky about mucormycosis and demystifying vaccines. Now, what is coming next? Do not miss. Our next academic delight is neurology for the practitioners on the 17th, note the dates, 17th and 18th of July. And there will be very interesting topics with neuroimaging teaching sessions for the pediatricians. I request doctors from the institution to submit posters and attend in full strength. At district level, what we're doing is a task force has been created by the DMO and other health officials, and we IAP leaders are also part of the task force. Early July, we are going to have physical training, hands-on training sessions on critical care management against COVID, which will be held at Medical College Thrissur for pediatricians and staff nurses. United, we are going to fight against this deadly disease. Another thing is that we, the IAP team of Thrissur, are very happy. We have arranged for the COVID vaccination for our family members. This is something which is so essential. How can we serve our society when we cannot help our family members who are the backbone? Our family is our backbone, and we can really work hard only if they are fit and healthy. So that is achieved, and by this weekend, mostly, hopefully, by the grace of God, that will happen. So I think that's the update for now. Thank you, dear members, and handing over to Dr. Anandakeshwan, sir, for the next part of the
Thank you, Dr. Reddy. Now I invited Dr. Jayaraman. Dr. Jayaraman is the state president. Then I invited Dr. Anju Deepak, the state president of ID chapter, to say a few words.
Thank you, sir. Respected Anandakeshwan, sir, Mohammad Gunya, sir, State Secretary Dr. Johnny, Thrissur IAP President Reti Madam, Secretary Srijita, senior IAP members, and dear colleagues. I'm extremely happy that Thrissur is doing a wonderful work with the I-Square series. I think this is the 5th program they are running, and one program better than the other. And I'm extremely happy that our Kunya sir is today's speaker with his start off. I wish all the best for the program. Thank you.
Thank you, Dr. Anju Deepak. And IAP Thrissur is hosting next Kerala State Pediatric Neurology Conference. And now you requested Dr. Mohammad Unis to release the flyer and brochure of IAP Neurology chapter and say a few words. Over to Kunju, sir. Kunju, sir. Kunju, sir. So IAP Thrissur is hosting.
So
Yeah.
I'm sure that. Yes. Okay. Respected the chairperson of Thrissur IAP, Dr. Redhi Shantakumar, Dr. Anandakeshwan, the past vice president of infectious disease chapter and all other distinguished members. I'm happy that we are Thrissur IAP is organizing this continuous program. And today, again, IAP Trivandrum is going to host the Thrissur Neuropedicon 2021. And actually, Anandakeshwan wanted to have it a physical meeting, but we all know that we cannot do it as a physical meeting. So it will be organized on a virtual platform. I'm happy to release the first brochure of the Thrissur Neuropedicon 2021. Thank you.
The dates are July 17th and 18th. So the theme is neurology for practicing pediatricians. So the attractive points are poster presentation for PG students, that is on 17th, intensive training on neuroimaging, that is under leadership of Dr. Mini, CME for practicing pediatricians, that is on July 18th, and epilepsy and rehabilitation on July 18th. So it's a very relaxed and a time scheduled session. So we have national and international speakers. So the one attractive point is that there is a poster presentation for PG students, and it is again on the virtual platform. So you have to send a poster of 500 words, and selected 10 posters we selected for presentation. That is on 17th Saturday morning at 10 a.m. Then we have a MRI imaging session, basics and beyond, infection, demyelination, brain malformation, and what else? Neurometabolic disorder. The leading speakers from SCT, SAT, and all over India. So I invite you for the workshop also. And on 18th, we have CME Pro section by opening batsman is around Kunyusa, early detection of autism. Then NMOSD and the MOGAD, head of the Department of SAT. Then we got a migraine and management by Dr. Shanas, neurological manifestation of COVID by Dr. Shiji. Then we got learning problems in children by Dr. GC, autoimmune encephalitis by Dr. Rasia, and the rare case scenario by myself. And then we have a symposium on epilepsy. Approach to first and provocation by Dr. Nidesh Vora from Ahmedabad, system mimics by Dr. Darshana Das, common pediatric epilepsy syndrome video demonstration by Dr. Lakshmi Narayan, Managing Status Epilepsy by Dr. Rosemary, and a Neurorehabilitation by international speaker Dr. Biju Hamid. So now I invite, thank you Dr. Kunju for releasing the flyer. Now I invite Dr. Mukesh is there. Dr. Mukesh.
No, he's busy. He won't be available.
Now I
Mukesh
invite
is
Dr. Johnny Sebastian, our State Secretary, to say a few words.
Good evening, all. Am I audible?
Yeah.
Respected Chair, Dr. Reddy Madam, IAP Kerala President Jayaraman Sir, IAP Kerala MBFHI Committee Chairperson, and the person behind this excellent webinar series, Dr. Ananda Keshavan Sir, the Doyen in the field of pediatric neurology and past IAP State President, Professor Dr. Mohammed Kunju, Dr. P.R. Jayakumar Sir, Dr. Jose Sir, Dr. Rajagopal Sir, Dr. Anju Deepak Madam, Secretary, and my friend Dr. Srijit, other dignitaries on this platform, and seniors and dear colleagues. I'm extremely happy to see IAP Thrissur conducting regular webinars under this series. And as we have today with us an expert speaker, a speaker of national as well as international repute, and none other than Ananda Keshavan Sir as the moderator, we are definitely going to have an academic feast today. I wish this CME all success and all the participants a great learning experience. And one more thing I wanted to add is that IAP Thrissur has again come up with Neuropedicon 2021, a 2-day excellent CME which is going to be very useful for all the practicing pediatricians. So I request all those who are present here today to support and participate in Neuropedicon as well. Thank you. Jai Hind, Jai IAP. Thank you.
Thank you, Dr. Johnny Sebastian. Dr. Jose is there? Dr. Jose?
Yeah.
Few words. Yeah, to say a few words.
ഞാൻ ഓൺ ട്രാവൽ ആണ്. ഓക്കെ, റെസ്പെക്ടഡ് രതി പ്രസിഡന്റ് ഓഫ് തൃശൂർ ഡോക്ടർ രതി madam and Dr. Ananda Keshavan sir, our teacher Dr. Mohammed sir, Jayaraman sir, Johnny Sebastian and Srijit and all the senior members. I think Thrissur is conducting a wonderful academic feast for last several days. They are conducting series of last CME also I attended. It was a very wonderful mucormycosis and the immunization series was excellent. I think that was enjoyed by a lot of pediatrician and practicing pediatrician. That was enriching our knowledge. And this is, as Reddy Madam mentioned, this is also a very informative. It will be an informative talk by Dr. Mohammed sir, and it will be very useful. And congratulations to IAP Thrissur for hosting the Neuropedicon 2021, and Dr. Ananda Keshavan doing a wonderful academic for Neuropedicon as well as all the activities Thrissur and state level and national level. So all the best for the program. Wish you all the best. Thank you. Thank you for.
Thank you, Dr. Jose. Now I invite the main man behind our Neuropedicon is Dr. Rajagopal. He is the president of the IAP Neurology chapter. And I welcome Dr. Rajagopal to say a few words.
Respected Kunju sir and other dignitaries. First of all, I would like to congratulate Reddy Madam, Srijit and Ananda Keshavan sir. They are organizing Thrissur Talk series in a wonderful way. This is the 5th one of it. At present, at the outset, I am here basically to invite you all for the Thrissur Neuropedicon to be held on 17th and 18th of July, a 2 days academic feast. I request maximum participation from all of you. Thank you.
Thank you, Dr. Rajagopal. We also request all faculty members, to medical college teachers and dependent training teachers to send a maximum number of posters to our state pediatric neurology conference. With this, now we'll start the scientific program. Today, we already mentioned Dr. Kunju sir. I think he needs no introduction among us because he was the past president of IAP Kerala, past national president of IAP Neurology chapter. He is dean faculty of the Kerala University, and sir was a executive board member of national IAP, and sir written so many textbooks, edited so many books, and wrote chapters in so many books. So with this few words, I'll go to the subject proper. acute encephalitis syndrome. Always a problem in management of acute encephalitis syndrome is a problem for general practitioners, how to diagnose, how to treat, and how to differentiate from other condition. And majority of the cases got a good treatment, but still is in many of the cases got also not very good prognosis also. So with the few introduction, I invite our great Kunju sir for his to deliver his talk. Over to Kunju sir.
Okay, thank you, Dr. Antakesh and Thrissur IAP for inviting me to deliver this presentation. I think before starting my actual presentation, I must say a few words because our Dr. First of all, I must thank again Antakesh for the nice introduction. And the statement that he has mentioned at the last thing, that means for many of the diseases, we don't have a treatment. But I think that is the major problem. This I have been telling in different forums as well as to my students, that the modern medicine people, always we all want a single shot cure for everything. And again, because of that, we say that we don't have a treatment for Nipah, we don't have a treatment for a Japanese encephalitis, we don't have a treatment for COVID-19 like that. Because I think this mindset has come after the invention of penicillin. Because we all know that penicillin is a curative drug for pneumonia. And after the advent of such a medicine, we all want such treatment modalities, and we want a sure short cure for everything. But see, when Japanese encephalitis came, again, that was the problem. When the dengue came, we were all telling that we don't have a treatment. So the Ayurveda people came with the pineapple and other things for management. But what we are doing, we make a diagnosis of dengue, then we look for the associated complications. We manage it depending upon the platelet count, we manage the shock, we manage other problems, and then that way we save the patient. For Japanese encephalitis, they'll be having severe intracranial hypertension, other complications, they'll be having electrolyte imbalances. We manage all these things and then we cure the patient. But still we will say that we don't have any treatment. But Ayurveda people, homeo people will come with something and they have everything, and people all believe it. So that is the major problem. I think we all must start telling the people that the treatment that we offer, the oxygen that we give for the management of a patient with COVID pneumonia is the treatment that is required for that patient. And whether you give, say for example, in herpes simplex encephalitis, we have a treatment that is the acyclovir. But even when you give acyclovir, the treatment has to be given for 10 days, minimum 10 days, 14 days, 21 days, like that. Even for a pneumonia also, for meningitis, where the treatment is available, you give drug for a different period, for 5 to 14 or 21 days. So that means you have to manage the patient through that period. And a condition like COVID pneumonia, where it has its own time, we have to manage them. So that is so, and I think as far as possible, we all should not be telling that there is no treatment for other conditions that we manage. We are managing with the specific findings, specific thing like that. So I think with that descending note, I will start the presentation, because I have put it as the febrile encephalopathy in children, because we all must understand that many of the febrile illnesses can be due to an infection, or it can be due to non-infectious inflammations also. Because the most important, the encephalitis or encephalopathy in recent past is the Paracore encephalitis. Initially, people thought that it is a viral encephalitis, and because there will be mild fever for that patients, they'll be having encephalopathy, and many were dying. And then later they found that it is due to the intake of lychee, especially in those children who are starving, and then they develop a state of hypoglycemia because of the metabolic inhibition of glucose, and so they develop a hypoglycemia, and their management of hypoglycemia has improved the outcome. But those patients also were having fever at least at some of the time. So many of the encephalitis and encephalopathies may have fever. So that is why febrile encephalopathy can be due to an infectious illness or a non-infectious illness that we must all remember. I think we all are trying ourselves to cure as well as conquer each maladies that are coming. And earlier we were all able to manage Nipah and able to control it very fast. And later we understood that we all started sharing the burden of management of this thing. And we all know that Dr. Sarida, a pediatrician, was in the helm of affairs for the management of both COVID-19 as well as for the Nipah management. After setting all the background work and actually having all the results, she has retired, and we must all upload her services. And being an IAP member, we are all must be happy that she is a pediatrician and she has done her own metal in a best manner. Where many would have failed, she has actually succeeded in the management. And I had just kept this Lancet editorial at that time when the Nipah virus was actually actively occurring. In June 9, 2018 itself, Lancet has written an editorial on Nipah virus control needs more than R&D. And actually that is more applicable for the management of COVID-19 infection also. At that time itself, they have predicted many diseases like which were present at that time, which were in an epidemic portion like Crimean Congo hemorrhagic fever, Ebola virus disease and Marburg virus disease, Lassa fever, Middle East respiratory syndrome, coronavirus, MERS-CoV and severe acute respiratory syndrome, Nipah and Nipah viral diseases, Rift Valley fever, Zika, and they have included disease X also. And in
slides
2000,
are not focused, sir. Any connection? Not focused.
I think you can't read it. I'll do one thing. I'll just move away from here and sit in a different place so that the transmission will be better.
So please write your questions in the chat box. If you have any neurological, not only this topic, any neurological topic, you can type in the chat box.
Somehow the slides are not coming in a correct manner. There is some clarity problem is there. Okay. So anyway, I think because my slides are the font is a bit large, so I think you'll be able to see them in a better manner. So, now coming to the after the Nipah, we have the Nipah virus. It is a definitely encephalitis process where the manifestations were mainly ARDS along with the neurological manifestation, especially that of a brainstem manifestation and severe encephalitis. But COVID-19, which was started, outbreak in 31st December 2019, and by 7th January 2020, virus was identified as a coronavirus, and 95% were in homologous with the bad coronavirus, and 70%, more than 70% had a similarity with the SARS-CoV. So it was later termed as COVID-19. And you can see that 30th January, because 7th January, 31st December it has started, but in 30th January itself, the first case was reported in India. And the manifestations of COVID-19 and neurological manifestations are not that severe or common, unlike Nipah or other viral infections. Earlier, SARS or MERS and COVID-19, the neurological components were obviously not the major focus. The main focus in respiratory, and but we all know that the manifestations are changing day by day. And COVID-19 and neurological diseases, the most of the neurology journals are inviting purpose, and whichever manifestations are there, if you send, they'll be publishing it very fast also. And major manifestations, especially one of the largest published study, 214 patients, including 88 of these were severe COVID infection, can see that 17% had a headache as a manifestation, and encephalopathy in 14%, or all cases when it is taken only 7%, and dizziness. Stroke was another manifestation. Again, when compared all the cases, 2.8% were having a stroke. And then hyposmia, if you take as a manifestation, I think in this they have in this study they have found only 5.1%. And other manifestations like ataxia, seizure, neuralgia, all were seen in this. And the initial report was a case of a single case report of an encephalopathy, where a 75-year-old man had encephalopathic features, and the MRI was suggestive of an acute necrotizing encephalopathy, where you can see that there is a necrotizing encephalopathy involving that arrow you can see there, where in the thalamic and basal ganglia, severe hyperintensity, and the SWI image is showing in hemorrhagic necrosis. So that was about the viral COVID-19 and the neurological manifestations. As Dr. Reddy has mentioned, I must be telling about the basics. So we'll know our basic understanding about the encephalitis and encephalopathy. Well, what is meant by an acute encephalitic syndrome? Because WHO has defined acute encephalitic syndrome, because an acute encephalitic syndrome is defined as a person of any age at any time of year with acute onset of fever and a change in mental status, including symptoms such as confusion, disorientation, coma, or inability to talk, and or new onset of seizures. So that means clinically a case of acute encephalitis syndrome is defined as a person of any age at any time of year with the acute onset of fever and a change in mental status, including symptoms such as confusion, disorientation, coma, or inability to talk, and or new onset of seizures. This will exclude the simple febrile seizures. So I think from this definition, we all can understand that the acute encephalitic syndrome is an encephalopathic process where one will be having a altered sensorium and a seizure as a manifestation. Okay. Then coming to the fever, as I have mentioned, any febrile illnesses or fever of anything that increases the body temperature with an altered sensorium can be considered as having a febrile encephalopathy. And the manifestation, when there is a signs and symptoms of infection, then there is a manifestations of that means fever must be a manifestation signs and symptom of infection. When there is signs and symptoms of meningeal involvement, where the symptoms are a headache, neck pain, and rigidity, and when these manifestations are there, we can call it as meningitis. That means meningeal signs with fever. But when the meningeal signs are not that dominant, but with a severe obtundation, coma, and seizures, then we'll make a diagnosis of encephalitis. So in these both the situations, we may go for a CSF examination, which will show a cellular CSF, and EEG and imaging manifestations also may be there. As I have mentioned, the febrile illness can be due to inflammatory involvement of CNS. It can be either infectious inflammation or a non-infectious inflammation. So infectious inflammations again can be classified as bacterial, viral, post-infectious, viral manifestations can include a acute viral infections, post-infectious infections, or a slow viral encephalitis like SSP or other prion diseases. Protozoal, recently also we all heard about the Naegleria or amoeba-related encephalitis. Then helminthes also can produce, especially the eosinophilic meningitis as well as encephalopathy. Then fungal meningitis is another infectious inflammation of the CNS. And non-infectious inflammations, among the most important nowadays is the autoimmune encephalitis, then malignant encephalitis and vasculitis. Again, we all know that vasculitis like SLE or even polyarteritis nodosa can present, or CNS vasculitis can present with the encephalopathic features. So when there is an altered sensorium, is there a clouding of consciousness or a coma? That means it can be either a lethargy, obtended, stupor, coma. At any stage, we can call it as an altered sensorium. And always, as we have mentioned, it can be acute encephalitic syndrome. So AES. So we can remember this always. I tell to my students as well as whenever I present this, because acute encephalitic syndrome. So you can use the mnemonic as AEIOU, the vowels. Because A for anoxic, because anoxic encephalopathy sometimes may masquerade as a febrile encephalopathy. Then toxic or alcohol or other toxins. Then epilepsy, because we know that even especially non-convulsive status may present with encephalopathic type feature. Then status epilepticus can present with again encephalopathic feature. Then I for infection, because already we have discussed, this infection can be acute infection, post-infectious demyelination, para-infectious demyelination, or we can have slow viral infections also. Again, injury, as many times can present as, because we know that especially diffuse axonal injury. Diffuse axonal injury may have only encephalopathic features, nothing else. And then O for opium or external toxins, as we have mentioned, the lychee, encephalopathy. Then uremia or internal toxin. When it comes to in children, again, it can be an acquired metabolic diseases like hyperglycemic encephalopathy, uremic encephalopathy, hepatic encephalopathy, like that. And again, inborn errors of metabolism also must be remembered. Again, we must understand that fever may precipitate an inborn error of metabolism as an encephalopathic feature. Especially, we all know about the glutaric aciduria, hyperammonemic syndrome or a urea cycle disorder. All these conditions also can present as acute encephalitic syndrome. So again, the points by which you can remember the etiological profile of encephalopathy. For that, we have to look for certain characteristic features. We'll start with this child who had developed seizure, 3-year-old child developed a seizure in the early morning. There was no fever or mild suspicion of a mild fever. It was an early morning seizure. So what should be all of you, some of you can give the answer in the chat box. What will be the, what test, simple test that we must be doing when the child is brought to the casualty? Can anybody answer? Yes, very good. Dr. Pratibha has written that you do a blood sugar, and so blood sugar is done. And along with that, will you do anything else? Again, Dr. Pratibha, you will do only that one. Again, you must understand this. Ideally, you must do a blood sugar estimation. You must take the blood and send to the lab. Yes. Then we must do Dr. Aparna. Yes, very good, Dr. Reddy. Also have mentioned that we have to do a urine ketones, because this may be a case of ketotic hypoglycemia, because number of times children presenting with altered sensorium and seizure, or even with an altered sensorium, and they are brought to the casualty without even knowing that child had a seizure, you must be thinking of ketotic hypoglycemia also. Then coming to another entity, where again child, so that means early onset early morning seizure in a comparatively thin child with a less muscle mass. Think of ketotic hypoglycemia. Then another, which is again eminently treatable condition, but the only thing is that you have to look for other causes of hypoglycemia, including fatty acid oxidation disorders, glycogen storage disorders. So these conditions also you have to remember. Then many children who presents with a behavioral abnormalities, considered as a psychiatric manifestation in the initial phase for 4 or 5 days, with a previous preceding history of a prodromal flu, etc., and then developing muttering to self and other manifestations. So here the child is just muttering to self with a behavioral change. Even this child also was considered as having initially. Then when the next phase, that was he stopped talking, and there was alteration of the sensorium, and then he developed the characteristic feature, that is the facio-brachial dystonic seizures. Here again, look at that the shoulder movement and the facial rubbing movement, and you can look, if you look carefully, you can see that the facial movement also. So this is a facio-brachial dystonic seizures, and some people call it as a stereotypic movement, and some people call it as a basal ganglion seizures, and some may be having a oculogyric crisis-like manifestation. Just look at that eyes. See that, I think all of you can see that oculogyric spasm as an acute presentation again in a child with an altered sensorium. So that is the second or third phase of a facio-brachial dystonic seizure. Then now we have the fourth phase of hyperkinetic phase, where the child will be showing very severe limb dyskinesia, bruxism, lip and tongue biting, dystonia, complex stereotype movements, opisthotonus, oculogyric crisis I have described, and choric movements. When all these manifestations are there, only one diagnosis nowadays, that is autoimmune encephalitis. I think now you know how to make a diagnosis, because of behavioral change, then seizure-like or a stereotypic movement, then hyperkinetic phase, and extrapyramidal manifestations, then you will make a diagnosis of autoimmune encephalitis. Also a prodromal phase, behavioral change, then facio-brachial dystonic seizures, hyperkinetic phase, and most of these patients they will recover by the management with a combination of IVIG and steroids. And this can be considered as the second most common autoimmune encephalitis after ADEM, that is acute disseminated encephalomyelitis. Again, another condition with a post-infectious demyelination syndrome. And most of the children in autoimmune encephalitis will be having an NMDA receptor antibody, which can be demonstrated by doing a CSF study. And the same child, we can see that after the treatment has become has become normal. He is crying. So we can see some more children who are having almost the similar manifestations with see again the movements. Even now, see that catatonia, waxy flexibility. See that catatonia, catatonia in that yellow child is keeping the head, upper limb in an extended position. Catatonia as well as a waxy flexibility also can be demonstrated in these children. Most of these children will be having a normal MRI. Very rarely only we will get a limbic encephalitic like manifestation. You look at that, see the limbic encephalitis like manifestations you can see there. See, that is the limbic hyperintensity involving the perisylvian insular cortex region. Just look at that, and that is it. But some children may have a basal ganglia hyperintensity also, but most of them will not be having any manifestations, as you can see here. This is another child again with who also had a very stormy course, who was there, and see the dystonic posturing. See, look at that dystonia. So dystonia is also a very helpful sign to make, and see that hand stereotypic or a basal ganglionic seizure-like manifestations, and look at that facial movement. In spite of that, they'll be having some amount of communication ability. That is the most important point. The same child, after treatment of almost 3 months treatment, has become all right. She has come to the casualty, and you see how she is normally, and she has improved. So even though the patient will be in a very, very dilapidated state in the acute phase, by giving a good treatment, immunomodulators, we can definitely manage them, and there will be a good recovery. And then coming to the next condition with an altered sensorium and abnormal movement, and predominantly Parkinsonian features occurring in an epidemic setting, that will be Japanese encephalitis. Here again, you can see that they will be having a severe extrapyramidal manifestation. You can see the dystonia with the Parkinsonian, some features, rigidity, etc. Then we may have to ask for their epidemiological factors. Of course, a child or an adult who is coming from an area where migrating birds are coming, or say again, or a duck farming area, then again you will have to think of herons or horned herons, or an egrets or a ducks, and the manifestation almost may be similar to the autoimmune encephalitis, but again we will have to think of a Japanese encephalitis, especially when the MRI is showing this sort of a picture, and especially when there is a non-enhancing or an enhancing lesion, the thalamus, basal ganglia, brain, midbrain, and pons. So we can make a say there. You can see that arrow is coming there. So there are basal ganglia hyperintensity and thalamic hyperintensity. So it is Japanese encephalitis. So make a diagnosis of Japanese encephalitis when a child coming from a probable area where Japanese encephalitis can occur. Recently also, we had 2 cases of Japanese encephalitis from Tirunelveli region coming to us. And one patient, and because the 2 patients came here, we contacted the Tirunelveli medical officer, and then we understood that there are a few more cases of Japanese encephalitis was occurring there. And see there, this is considered as the giant panda sign also. Okay, and another encephalitis that can present with again extrapyramidal manifestation is almost similar to JE as well as dengue would be West Nile virus. Here again, the initial signs and symptoms may be non-specific, which may include a fever, malaise, periocular pain, lymphadenopathy, and myalgia. But the additional manifestation, extrapyramidal manifestation, then you think of a West Nile virus encephalitis. So extrapyramidal manifestations can be seen in Japanese encephalitis, West Nile virus encephalitis, autoimmune encephalitis. And in these situations, we may have to remember at least 2 other conditions, especially in young infants. You may get an acute necrotizing encephalopathy with a striatal necrosis, and again a basal ganglia. Biotin thymine response to encephalopathy also has to be remembered. So in such situations, we can give a high dose biotin plus thymine for the management of that presentation. And then coming to the focal encephalitis, because when an encephalopathy like picture with a fever and focal seizures, loss of speech, especially initially the patient may have a comprehension impairment because the temporal lobe involvement, comprehension involvement. And then they may have a motor speech loss also. So that means involvement with the frontal lobe. So temporal lobe may have a difficulty understanding the speech initially, then difficulty producing speech. Then such situations where an EEG may help. So EEG will show the typical floods, that is a periodic lateralized epileptiform discharges can be seen. That is the flood. So again, I think there is the slide is not that clear, but anyway, we can understand that asymmetry in both the sides. Okay. So this is floods, periodic lateralized epileptiform discharges. Suggests a focal encephalitis. That is the most important point in this. So, and MRI will be showing a hyperintensity involving the, see here you can see the temporal lobe involvement as well as the frontal lobe involvement, because it is a frontotemporal encephalopathy, that is herpes simplex encephalopathy. So look for they can have a focal seizures, hemiplegia, behavioral changes, etc. And we have what the treatment, all of you know that we have to give acyclovir at least for 14 days. And if there is no improvement, you go for a repeat HSV PCR. If it is positive, you give a drug for 7 more days. Or if PCR is negative, we can stop treatment. And the clinical, I have given certain clinical clues for at least making certain specific encephalitis syndromes. And now sometimes the MRI may be helpful. And the following will be the MRI features in some of the typical encephalopathies. Here you see that there is a white matter hyperintensity, and some amount of petechial hemorrhages seen. And this may be seen in a case of viral encephalitis, especially secondary to Paracore Virus encephalitis. Okay. Then coming to the next type of MRI. So this is a Paracore Virus, but this can occur in a newborn child also, especially this sort of finding can happen. And coming to the next characteristic finding may be a boomerang sign, because where you can see that hyperintensity involved in the corpus callosum. So this sort of finding can happen in H1N1 encephalopathy, or even post-ictally also it may be seen, and also in Adam also you may be seeing this sort of finding. But in early phase, so that you get in this one is a diffusion weighted index, then you may make a diagnosis of H1N1 encephalopathy. And recently we have seen this sort of finding in a case of dengue encephalopathy also. And then the very typical MRI finding, because you have a encephalopathic feature, there may be fever or may not be fever, there is a focal neurological deficit, and there may be a past history of fever. Then the MRI finding, where you can see that in addition, there is a white matter hyperintensity is there, along with the look at that basal ganglia and thalamic hyperintensity. Then we will make a diagnosis. You can see that thalamic hyperintensity. Then you can make a diagnosis of acute disseminated encephalomyelitis or ADAM. There again, you see here, you can see that there is a hyperintensity involving the white matter region. So especially it is bilateral but non-symmetrical. But again, you can see that patchy areas of hyperintensities. Nowadays, and again, you can see that a few patches are there in the brainstem also here. And again, this can be due to MOG or myelin oligo antibody related encephalopathy. And here again, you can see that the white matter hyperintensity can be seen here. So this is an extensive hyperintensity involving the white matter, very typical of a acute disseminated encephalomyopathy. And look at that white matter involvement as well as the deep gray matter involvement, where you can see that the thalamic as well as the basal ganglia hyperintensity in a case of acute disseminated encephalomyelitis. When the hyperintensity is involving the gray matter, we may make a diagnosis of a gray matter encephalitis. But again, gray matter encephalitis, which you may not be seeing this much hyperintensity in many of the patients, but milder hyperintensity in the gray matter, we will be getting the report as a viral encephalitis. So this is a non-specific finding, but again, definitely you can say that this child must be having a encephalitis due to a viral infection. So it is a gray encephalitis. Gray encephalitis. Definitely, most of the encephalitis are a gray encephalitis, but white encephalitis is a leukoencephalitis. Then remember that when a child presents with altered sensorium, then with the altered sensorium or a somnolence, just make the patient awake and then make him walk. Then you will get a diagnosis, because when making a drowsy child walk, attacks out of proportion to his drowsiness. We all know that a drowsy child will be a bit ataxic, but the ataxia are definitely out of proportion to the drowsiness. And if you make him again alert, then you can make a triad of diagnostic clue. That is the look at the eye movement, that is ophthalmoplegia or a peculiar eye movements like ocular flutter. Again, you can see that ocular flutter. Whenever the child is moving the eyes, there is a flutter-like movement. And ophthalmoplegia is a diagnosis of a brainstem encephalitis. Where again, most of the time the MRI will be normal, because the findings will not be there in the MRI. But in this case, you can see that the basal the brainstem. See, the brainstem is showing a hyperintensity. Yes, you can see that brainstem hyperintensity. Just showing that arrow there. So this is the brainstem encephalitis. Brainstem encephalitis, because here, so an altered sensorium, ataxia, and eye movement abnormality, especially the up-gaze restriction, we can make a diagnosis of brainstem encephalitis. So I think that again was a clue for making a diagnosis of brainstem encephalitis, which has got a very good prognosis. Now we have another sort of encephalopathy, that is acute necrotizing encephalopathy, where we can see that extensive basal ganglia as well as a thalamic necrotic lesion. This is CT scan showing severe hypodensity. As I have mentioned, this can be due to various disorders like acute necrotizing encephalopathy or a biotin timing responsive encephalopathy. And this there is again a rhombencephalitis and Coxsackie virus A16 EV71, and this had a hand, foot, and mouth disease prior to the occurrence of this acute necrotizing encephalitis. Okay. So now comes the other viral encephalitis, because we know that as we have mentioned, the virus infection can produce various after effects also, as we are seeing in COVID-19 infections also, because we can get an acute viral encephalitis, a viral triggered demyelination, as we have seen in a case of Adam, or a viral decompensated underlying inborn error of metabolism. I told you that an encephalopathy can be precipitated by a viral encephalitis. Then in children, even though autoimmune encephalitis is said to be secondary to a paraneoplastic process, both in adult as well as children, but many times autoimmune encephalitis is said to be triggered by viral infections in children. Then another situation is called as FIRES, or a viral precipitated non-convulsive as well as a convulsive electrical status. Then finally, we can have a viral induced vascular insult or a stroke-like presentation. So see, the virus can have different type of presentations in the brain also. And among them, we all know about the varicella producing varicella cerebellitis, because cerebellar encephalopathy can be produced by varicella, where you get more of an upper limb ataxia, or a upper limb, that means finger nose in coordination, will be more affected than a gait ataxia. But again, varicella can produce varicella zoster vasculitis, or a viral induced vascular insult presenting with a arteriopathic stroke. And it is said that characteristically involving the basal ganglia, insular cortex, and thalamus is said to be very much characteristic of a viral induced, especially zoster encephalitis or a vasculitis. And the dengue virus, because we all know that dengue virus presents with shock syndrome, but encephalopathic feature can occur in the acute phase itself, or some children may present with encephalitis itself as the primary manifestations. So it may, and other altered sensory can occur because of the hypertension, cerebral edema, microvascular and frank hemorrhages, hyponatremia, and fulminant hepatic failure, which may be part of a Reye's syndrome. Okay. Then the another infection that can lead to because of the infection, that rickets cell infection that can produce encephalopathy would be scrub type, because number of children we have admitted in neurology also with a continuous or a low grade fever for many days, with a because presenting as a PUO with encephalopathic features. And it was, you know, that if an eschar is seen, easily the scrub typhus may be diagnosed. But many times we diagnose, because sometimes eschar may not be visible, and we give tentative treatment for this one, and they will treat. So this is one of the studies whereby an acute encephalopathic process with special reference to viral etiology, various manifestations can occur secondary to viral infections. And the manifestations that I think the slide is not readable, so I'll just pass on to the next entity, that is sepsis associated encephalopathy. This again is considered as a common entity in adult. In I think 30% of ICU encephalopathy is said to be sepsis associated encephalopathy. This, but the exact mechanism of the CNS involvement is not known. But it can be associated with a bacterial invasion of the brain, or endotoxin related inflammation, or a derangement of the neurotransmitter and amino acid microvascular changes. Anyway, this can be secondary to various infectious processes. And another encephalopathy, even can be seen in a child, would be HIV encephalopathy. The manifestation may be HIV virus itself, or its neurologic complications, and secondary to opportunistic infections like CNS tuberculosis, CMV encephalitis, toxoplasmosis. Number of children I have seen HIV encephalopathy with toxoplasmosis, then cryptococcal meningitis, associated syphilitic meningoencephalitis, then primary CNS lymphoma, or a drug-related complications secondary to the HIV treatment. These are all some of the encephalopathic causes of child presenting with the HIV infections. So this is the geographic distribution of Nipah virus. Again, we all must be always careful about an infection spreading, and especially when there is some atypical features are there in a child who presents with encephalopathy, we must be looking for newer and newer or the disease X as advised by WHO. So if the differential diagnosis we can utilize when there is an epidemiological features that is helpful, as in a case of JE or a Nipah virus, or a person who is working in a bat infested area. Then we may have to think of virus infections like Nipah, or in a farm area or a pig rearing area, think of Japanese encephalitis, then mosquito bite, think of JE, dengue, West Nile virus encephalitis, working or playing in dirty water, leptospirosis, history of animal bites, rabies, because rabies itself is encephalitis, especially a brainstem encephalopathy, but I'm not covering it. Then contact with tuberculosis, think of tuberculous meningitis. Then a child presenting initially with psychosis, you can think of HSV, herpes simplex viral encephalitis, or a limbic encephalitis, or autoimmune encephalitis. And Korea, extraterminal manifestations, you think of Japanese encephalitis, Adam, when there is a meningeal signs is present, you can think of meningitis. When there is an asymmetric manifestation like a hemiplegia, focal seizures, think of herpes simplex encephalitis, tuberculous meningitis, Adam, when focal changes are there. Ataxia, I told you that ataxia, you think of a varicella zoster or Adam, or enteroviral encephalitis also, you can get ataxia as a manifestation. And visual loss is there. Think of hypertensive encephalopathy. So you should not be forgetting to take a BP in a patient who presents with an altered sensorium. And look at the fundus, because when there is a papilledema or intracranial space occupant lesion. When there is a lower cranial nerve involvement, is most of the time you may not get it, as I have mentioned, then it may be brainstem encephalitis, or a intracranial vasculitis, or a tuberculous meningitis. Then systemic manifestations like lymphadenopathy. You think of EB virus or a leptospirosis. Then hypotension and shock are common with dengue virus, chikungunya, leptospirosis, and hepatosplenomegaly may be seen in EB virus, dengue virus, lepto, HIV, collagen vascular disorders, etc. I think when a patient presents with a coma in a general situations, in an epidemiological situation for a field, we have to look for any rash. We know that when there is a rash is there, it may be because of a meningococcemia, stiff neck, shock, bulging fontanelle, etc. Then look for any sort of a capillary leak evidences, or petechial hemorrhages. Then when there is a look for any evidences of dehydration, etc. Then I think as we have mentioned, we must be looking for any hypoglycemic changes. In that case, we can think of a Rye syndrome or Lychee encephalopathic like manifest. In areas where malaria is endemic, then think of a cerebral malaria also. In that case, we have to do a malarial parasite examination, then that may be helpful for a diagnosis. Because in Kerala, we may not be always thinking of malaria encephalopathy, but in an occasional case, when a child is brought from another area where malaria is there, think of malaria encephalopathy also, especially when there is a persistent hypoglycemia, severe edema, then think of malarial and cerebral edema. And as I have mentioned, we can't stop the discussion on encephalitis when a condition called as febrile infection-related epilepsy syndrome, when we have excluded everything else, whatever we have discussed earlier, but a child who is continuously having seizures with a febrile fever persisting for weeks, then we may make a diagnosis of a febrile infection-related epilepsy syndrome. And here again, it may be a fever-sensitive epilepsies like SCN1A mutation encephalitis, or a gene-associated infections like Alpers syndrome, etc. So we all know that infections or all diseases has a tropism, and we have understood that HSV has a tropism, that is frontotemporal involvement. Rabies will be producing a brainstem encephalitis. So polio itself shows that it's a gray matter encephalopathy. So polio also can produce a brainstem as well as a cortical involvement, cortical gray matter. Then cerebellar involvement is common with varicella, and basal ganglia. Already we have told that JE, Busnell virus, and autoimmune encephalitis. And these are the viral tropism that I am mentioning. Enteroviruses, because can have a myelopathy with the encephalopathy, or even a Pons or a medulla involvement, and Nipah virus associated more with the brainstem manifestations. Okay. So Adam, all of us know that it's a leukoencephalitis with some gray matter involvement also. So this is the tropism of viruses. The newer viruses also may have its own tropism characteristics. So finally, we must all know the encephalitis also can be prevented, because most important thing would be to go for a mosquito reduction, the dry day observations, and giving vaccinations whenever it is available, because Japanese encephalitis is being eradicated, almost eradicated from the endemic areas like Trivandrum and Alleppey by the vaccination of Japanese encephalitis. And even the community vaccination, actually, when we were doing Japanese encephalitis vaccinations, you can see that the vaccination is being even done by the mobile, using the mobile units when Japanese, and actually this was a photography when we went to the Vizhinjam for immunization drive. You can see me also standing behind there. So to conclude, whenever a child presents coma or an altered sensorium, you may have to look for an associated meningeal irritation. And if it is there, you know that it can be meningitis, meningoencephalitis, or subarachnoid hemorrhage. I'm sorry that you can't read it. So it is meningitis, meningoencephalitis, and subarachnoid hemorrhage. And if there is no meningeal irritation, that means look for any focal signs and symptoms. If it is there, then it can be suggested a focal encephalitis like herpes simplex encephalitis. If it is no focal signs or other manifestations, it can be other encephalopathies or a postictal syndrome. And remember the vowels, that is A, E, I, O, U, as my summary of the presentation, A, E, S. So never forget these things whenever you see a child with altered sensorium. And this, a child in a comatose state, confused state, or a delirious state, you remember this mnemonic, and this will be very, very helpful. Okay. So to conclude again by an MRI, we all know that we'll be asking for an MRI. And when there is a frontal or a temporal involvement, it is herpes simplex encephalitis. Even the thalamic or a basic ganglia hyperintensity, it would be Japanese encephalitis, and with a giant panda facial picture also. And when there is a gray matter as well as a white matter hyperintensity, it is diagnostic of Adam. So the last one is the Adam. And always remember that arboviral encephalitis in India, because they are Japanese encephalitis, then dengue virus. You get other regional viruses like Chandipura infections. Then again, Nipah virus encephalitis outbreak in Siliguri, West Bengal, Kerala, and West Nile virus. Never forget Kaisanan forest disease, because I haven't discussed it now, because we all know that monkey fever will be discussed also. Then chikungunya. So remember all these arboviral encephalitis that can happen in India. Thank you. I am stopping my presentations now. Thank you, Dr. Anandakesavan and Dr. Reddy, and all the organizers of this conference, including Dr. Anju, the president of or a chairperson of ID chapter. Thank you.
Thank you.
When you see this
sir.
basal X-ray, you make a diagnosis of meningitis, and if there is hydrocephalus, that may be helpful. Okay, thank you.
Thank you, sir. Please stop screen sharing. So thank you. We start with the coronavirus neurological manifestation, then infectious and non-infectious encephalopathy, then finally so many characteristic MRI pictures which will help to diagnose. We have a lot of questions in the chat box. Before that, I will ask the 3 questions. So, is there any case of acyclic or resistant herpes simplex infection? If it is, or will you get a better result with any other than acyclic?
Okay, I think people discuss about autoimmune, the herpes simplex encephalitis, which is resistant to acyclovir. But actually speaking, it is actually very rare. But again, by continuing treatment for 7 more days, I think we'll be able to manage them. Again, I think the manifestation may be because of other complications rather than the resistant HSV. But anyway, in such situations, it is said that either a Foscarnet or instead of acyclovir, we can go for a valacyclovir, which may have a better bioavailability. Valacyclovir, these are the drugs, Foscarnet and valacyclovir. These are the drugs advised for resistant HSV encephalitis. But most of the time, I think HSV will be sensitive to acyclovir. Only thing is that you have to give the correct dosage, and maybe sometimes you may have to give the correct brand also. We know nowadays most of the drug will be fake medicines also.
How will you diagnose fires? Because we had a couple of cases, high grade fever, seizure, then with poor prognosis. And
Yes.
how will you diagnose with fires?
Yes. Because actually, fires is a diagnosis of exclusion only. Because we go for all the diagnosis for all the etiologies that are possible, including autoimmune encephalitis. When we exclude everything, we don't have any viral, because we send a viral panel, we don't get anything. And when one is having a recurrent persistent seizures with a high persisting fever, then we make it, and this is commonly seen in school-age children. When this happens in school-age children, we make a diagnosis of fires.
Have you made diagnosis with the genetic test? Any genetic test is useful?
Already, I told you, because it is said that some genetic epilepsies like Dravet syndrome or a Paul G associated syndromes may manifest with as fires. So genetic testing may be helpful, but again, you know that in such situation, even in acute fires, people, acute status epilepticus, people may go for a ketogenic diet or a newer drugs, and IVIG, methylprednisolone, all will be tried in that way.
Last question, it may be a tertiary level care center question. So how will you treat NMDA receptor encephalitis or anti or autoimmune encephalitis after IVIG, corticosteroid? How is any regime for immunosuppressive or monoclonal antibody?
The regime, I will tell you. The regime, because as soon as we suspect the disease, ideally, because you do a CSF and then set it for NMDA receptor antibody. Usually, I start IVIG and methylprednisolone together. If you are sure that it is an autoimmune encephalitis, start with the IVIG and the methylprednisolone together. So IVIG, you start with the 400 milligram per kg per day, 400 milligram per kg per day for 5 days, and IV methylprednisolone 30 milligram per kg per day for 5 days. Then what we will do is we will continue with oral steroid at a dosage of 2 milligram per kg. We will wait for up to 1 week for improvement. By that time, we will be giving supporting treatment, etc., and continuing the oral steroid. If the patient is not showing improvement, then we will go for rituximab. Rituximab will be given for weekly for 5 days. And some people may use even cyclophosphamide 1 dose along with this one, and then monthly cyclophosphamide also will be given. And in those patients who does not respond to this regime, after the completion of 1 month, that means already, because 5 doses of rituximab will be given, and IVIG methylprednisolone is given. So by this time, it may reach almost 6 weeks to 2 months. At that time, if there is no desired improvement, we may go for another course of IVIG also. At that time, we will be going for other immunomodulators like azathioprine and the mycophenolate mofetil. And these drugs, either mycophenolate mofetil, azathioprine, or a steroid, may have to be continued for at least 6 months. And some cases, we may have to continue the treatment for 1 year also, with a periodic pulse IV methylprednisolone, periodic rituximab, etc. That depends upon the treatment. For that, there is no specified regime or a protocol, but you can give it depending upon the responses.
Any experience with the plasmapheresis for this condition?
Yeah, definitely. You can go for a plasmapheresis also.
So now I read 2-3 questions there.
Can I say?
Yeah.
Yes, madam. Say first your comment and then questions, madam.
Yeah.
Oh, it's always a pleasure to listen to Dr. Kunju.
Thank you.
And today I liked your mnemonic, AIOU, very much, AIOU. And regarding this malaria, years back, maybe 30 years back, I had a case of a 1.5-year-old child admitted with fits, and he had marked pallor and hepatosplenomegaly. So anyway, we thought of febrile convulsion or leukemia, we thought of, and we sent the peripheral smear immediately. And the pathologist, in few hours, they called us and told that it is malaria. Actually, the child was coming from Fatehpur, North India. So it was a case of cerebral malaria with convulsions. And what about this snail encephalitis? Have you any experience? Do you have any experience? Snail.
Snail. That is actually this sort. They can produce, especially the encephalitis when or a meningitis like presentations. You go for a CSF study, and when there is an eosinophilia, CSF eosinophilia is there, I can suspect that because somebody has asked. Okay, madam, that's it.
Snail.
When a eosinophils are seen in
eosinophilic meningitis. Okay. You had any case? Did you have any case?
Yes. I think that Amrita has reported number of
Amrita
cases.
also reported some.
Yes, Ernakulam, they have got lot of cases. Okay, thank you very much.
Thank you, madam. Now, Kunju sir, how early do we see changes in MRI in autoimmune encephalitis? As the autoimmune panel CSF may take time. So, how early will get changes in MRI?
Yes. As I have mentioned, more than 50% of cases or 60-70% of cases of autoimmune encephalitis, the MRI will be normal. Because in other findings, maybe non-specific hyperintensities may be seen or basal ganglia hyperintensities. And as I have shown, when it is a limbic encephalitis, you will get involvement of the hippocampal and insular cortex hyperintensities may be seen. Okay. And regarding the CSF finding, because usually in the acute phase when we do it, maybe because by the time the patient presents the movement disorder, the CSF must be positive. But there are reports of CSF negative autoimmune encephalitis also. But when NMDA receptor antibody is negative, we may have to go for other antibodies like VGKC antibody and GAD antibodies and other, because which are not available or which may be more costly. So in such situations, we may have to think of a maybe antibody negative autoimmune encephalitis and treat.
2-3 questions regarding CSF. Sir, could you please tell which CSF tests are practically available that can be sent to know further cause of encephalitis? Importance of CSF study in AES.
Okay. Because CSF, I did not go in detail because we are all, I think pediatricians will be doing CSF study without much hesitation. But I know that in private situations, people may be a bit hesitant to do it. But we as students, we were all taught that we must be doing as much lumbar puncture as possible. But anyway, when you are doing a lumbar puncture, make sure that you'll be doing it in a very correct manner. You will be able to send the specimen correctly, because sometimes in the middle of the night you will do the CSF study and you may not be able to do anything at all at that time, because when you suspect meningitis, definitely you have to do the lumbar puncture as early as possible. But I think in encephalitis you can differ a bit, because because whenever there is an altered sensorium, you have to get an MRI or at least a CT scan to make sure that there is no severe cerebral edema or no possibility of a cloning. And if it is not there, and examine the fundus as far as possible. And if there is no papilledema also, definitely you can do a lumbar puncture. Once you do the lumbar puncture, maybe you may measure the CSF pressure if possible, but collect the CSF at least in make sure that you are having 3 bottles, because sometimes it may be traumatic. So if you are having 3 bottles, definitely you can see that the 3rd bottle will be, if it clears, it will be it will be traumatic, because sometimes I have seen that when people get a so-called traumatic CSF, it may be a subrecurrent hemorrhage. It may be just labeled as a traumatic CSF. So collect it and keep it keep it for some time, or if it is traumatic, centrifuge it and look against a white background. That is more important. If it is a subrecurrent hemorrhage, then the supernatant will be that means it will be what do you call will be yellowish. But if it is traumatic, it will be definitely clear. So this clarity can be seen only if we keep the CSF in a bottle, in a glass tube or a bottle against a white paper. We keep a white paper and then look at it. Similarly, for whenever we are looking for a cloudiness of the CSF, because when we just look at the light, this cloudiness cannot be appreciated. For that, what you do is take plain water in one bottle and CSF in another bottle and keep it against a white background again. Keep a white background and see. Then you can see the difference of the cloudiness and clear CSF. I think that is a burst test, because when you are sending a CSF to the lab people are sleeping. They will just again, just like us, they will just lift and see. Okay, there are 3 to 4 cells per hyperfield, and they will just give you a report. So actually, the CSF has to be stained by using a Leishman stain, just like we do the peripheral smear, and then examine under the oil immersion for the differential count. And for total count, you have to charge the newborn counting chamber with the CSF diluted with the Turk's fluid. That is how we test the CSF cell count and CSF differential count. Just by doing a methylene blue staining, you can say whether there is only cell or not, because we can't differentiate the pus cell or a lymphocyte by just looking under the microscope with a high power. But oil immersion is required. You all know that when we were doing our peripheral smear examination under the microscope, both in physiology and pathology, because by just tilting, the neutrophil may appear as a lymphocyte. So just by seeing only under oil immersion, that is very, very important. Then you can differentiate. Then again, if you do this Leishman stain, only you can make a diagnosis of eosinophilic meningitis also. Otherwise, it will be definitely missed. Then biochemistry you have to send, because in viral meningitis, usually the CSF sugar may be normal with a slightly increased protein. That is diagnostic of a viral encephalitis or a viral meningitis. We know that bacterial meningitis sugar will be low, but sugar will become comparatively normal in a viral meningitis or a viral meningoencephalitis. But except in a case of lymphocytic choriomeningitis and mumps viral encephalitis, meningoencephalitis. Otherwise, CSF sugar will be normal in viral encephalitis. That is another clue for making a diagnosis of viral encephalitis or a viral meningoencephalitis. Then we have to send the CSF for viral studies, both for a culture or a PCR or a CSF IgG studies, because CSF viral studies, especially for IgM and IgG, we send to public health lab in Trivandrum. It is available, and they cater to private people also. That you can say. Then yes, in Alleppey Virology Institute also you can send. They will also give a report. Then sometimes we may be sending to Pune or to Manipal also. You can send. But usually in our place, like in Trivandrum Public Health Lab, they do for HSV virus, HSV 1 and 2, Parvo virus, Echo, Coxsackie, and then depending upon the periodic, this is see HSV, other HHV also they do it, HHV 6, HHV 7 they are doing. Enterovirus also they will do, but they are not doing enterovirus typing.
We got many guests from outside India, outside Kerala. One question: how to titrate from middle prednisone pulse therapy in a case of Adam?
But once again, some regimes like monthly rituximab for 6 months as maintenance in autoimmune. Some people, because when we are not getting response, rituximab may be given in a monthly basis also. Some people give monthly rituximab if a patient is having especially recurrences. But what I have found is that if you don't stop the steroid for 6 months, you give continuously for 6 months. But say not 2 milligram per kg, at least 1 milligram or 0.75 milligram per kg, then the recurrences will be less.
So practical questions are there. Best antiepileptic drug in viral encephalitis, one question. Second is it possible to prognosticate an autoimmune encephalitis at a diagnosis?
See, prognostication in the initial phase, if you start early, treatment very early, and early behavioral changes are less in the early phase, the hyperkinetic phase is less, then the prognosis would be better. But in say, a pubertal girl child, what I have seen is the prognosis may be poor because some may be a cryptic ovarian teratoma may be there, which may be missing. That may be the reason.
Any particular antiepileptic drug you want to advise for viral encephalitis?
See, that way we cannot say, but people use, because as usual we all go for phenytoin as the initial phosphenytoin. Nowadays we use levetiracetam, and what I have found is sodium valproate is very much useful in this IV sodium valproate, so you can use that. But only thing is that you do the blood liver function testing.
So another question related to this COVID: do you get patients with MIS-C with AES?
Pardon?
MIS-C.
MIS-C, yes. MIS-C, it is said that they can have we had a child who was in a case of a comparatively watered state and in a ventilated state, MIS-C, and that child was having a prolonged encephalopathic feature for many days. But most of the MIS-C will not be having much of an encephalopathic feature because they have more of a Kawasaki-like feature. That is what I have felt. But one of the patients who had this sort of a thing developed a severe critical illness neuropathy. One child developed a severe critical illness neuropathy after prolonged ventilation, a case of a MIS-C.
In the beginning, you mentioned about the stroke with COVID.
Yes.
We are also concerned with the post-vaccination stroke also. Means thromboembolic phenomena, TIs, so many things are there. So, means any other relation, means any extra knowledge about means COVID-related stroke, vaccine-related stroke, any extra risk, anything like that? Maybe more pure pediatric topic. Then also, can you highlight
young patients, because in the beginning of Wuhan viral epidemic itself, there also they said that around 3% of cases, especially when it was occurring in young patients, the stroke was one of the hemiplegia was one of the manifestations. Again, when I think 400 patients were seen, only 1 or 2 stroke, not that very high incidence. And regarding, I think the thrombotic incidences in after vaccination, especially of AstraZeneca vaccine or our Covishield, there are reports, but somehow from India we are not hearing much. I don't know whether it is underreported or not reported. I don't know.
Is the West Nile virus encephalitis reported from Kerala?
Yes. It was reported from Alleppey also. And we also had a West Nile. But it is said that there may be a cross reactivity between dengue and West Nile. So when we are finding out West Nile, it may be a cross reactivity with the dengue. Dengue itself may be showing in a child who is having a dengue infection. West Nile virus, a cross reactivity said that. But we are not sure so whether it will be a West Nile or a dengue.
Last question, I think it is a covered, means some regime like monthly rituximab for 6 months as maintenance in autoimmune encephalitis. Please comment, sir.
Yes, already I mentioned, because some people, even we have admitted patients which was being seen in other institutions where they have adverse rituximab. At least 3 to 4 times we have given it in our, when I was in SAT, because of the cost. When it is advised from private hospitals, they will come to us because of the RBSK program. We were able to give it free of cost. So they used to come there. But actually speaking, as I have mentioned, if an acute management is done in a better, in a very virulent manner, then the improvement would be better.
We have Purushottam sir with us. Sir, Purushottam sir, can you give some comments?
Kunju sir, sorry, I was late to join. I missed the initial part of the talk. A few points I would like to add is, we had before the Corona season, 2018, 2019, there were a lot of cases of septic meningitis bar encephalitis features from Malappuram, Pattambi, Pannani, Palakkad area. It was not less in number, it was around 200 cases or so within a span of one year. But the mortalities were less. Many of them, initially we treated with antibiotics, later we stopped because we had the typical features of LP showing neutrophils. But the blood picture were not supporting the bacterial. We initially started with the Ceftriaxone and all, we stopped later. And we did many cases sent to for the virological workup. It was not convincing. There were adenovirus, a few of them were there. And later, Dr. Vijaykumar, I hope he is here. There were a few cases of encephalitis with myocarditis also. And a few of them were, I think in Calicut, they lost a few cases due to myocarditis. There were encephalitis with myocarditis features. And one very important point we need not forget is the presentation of loose stools with encephalitis seizure situation, where it is all many cases of Shigella soni presenting without blood in the stools, and there were hyponatremia, encephalitis features, and the fast progressing type. So every year, Calicut, Malappuram area, we are facing many cases of Shigella soni with typical encephalitis features and fast progressing, and death also few cases which occurred. So hereafter, we should not be missing cases of unusual organisms other than the virus also, like Streptococcus, many cases are presenting with encephalitis, where it's eminently treatable. Doxycycline and other macrolide groups should be given a bit early, so if there is suspicion. KFD is one entity which are already said it is confined to Wayanad, but in the coming years, there is every possibility that all these zoonotic diseases are very likely to be reported in the other states also. It will not always be restricted to Wayanad only. So we should be aware of all those situations. And sir has must have completed the neurological features of the corona. And corona can be stroke is the virus as such, encephalitis is there, and the immune mediator is there. And sir has already said MISC period there is a seizure, that becomes a more of a difficulty because the LP will be more difficult because you are giving anticoagulants, you are giving aspirin. Unlike the situation where it occurs in the initial phase of the corona, where LP can be done easily. The other situation, LP proof is difficult. So empirically, you will be giving ceftriaxone, you'll be giving doxycycline, and you'll be giving the steroids. Under cover of the steroids, you'll be covering the the pyogenic cover also. I would like to comment about the last slide of the algorithm of encephalitis. So any altered sensorium with seizures, when there is no fever, it can be any of the other disorder. When there is a fever, it is likely to be encephalitis situation where you said you categorize it as an focal generalized and a group with dystonic posturing with extrapyramidal signs. And these are all helpful physical findings which will be helping for the etiological thing. There, the first point is the epidemiological aspect which will be very helpful to pinpoint which one is likely. Second is the associated system involvement. We all forgot about the Nipah situation where there is an altered sensorium, abnormal situation with the respiratory involvement, unexplained ARDS-like situation with the encephalitis feature, and the most important thing there will be the autonomic disturbances. So an encephalitis situation where autonomic findings are there with the respiratory involvement. Even though Nipah is eradicated in the coming year, with this constellation of findings, you should not forget that the possibility of a Nipah anytime it can come back. Then about the West Nile virus is another clue about the West Nile virus in the neurological examination is the angle jerk. This is one finding, one encephalitis where there can be an flaccidity and absence of reflexes, angle jerk. There can be a UMN sign in many of the encephalitis. The tone will be high, the jerk will be exaggerated, but in a West Nile situation, the clue is that there can be hypotonia and angle jerk loss. The peripheral involvement is one clue. Sir said this about the diagnostic clue. We will be sending the CSF for the JAB study, serology for the JAB study. There again, false positivity is possible in a case of West Nile in the JAB also. So you can get a JAB positive. Many of the cases of the typical features of extrapyramidal, seizure, everything, you'll be considering JAB because you get the serological report as JAB. Only when you ask for a repeat studies, do look for the West Nile, you will know that West Nile, there's a false positivity of the West Nile disorders with the JAB also. So unless you ask for a West Nile study, you may miss. All these things were done when Arun Kumar was there in ICMR, that we got very good help. All those Nipah period, we have been discussing about all different types of encephalitis, the rarest of the situation, Chandipura, and the many Lichis are also mentioned, Gorakhpur, epidemic situations of the encephalitis were there. Still now, you don't know what exactly is it hypoglycemia due to Lichi? Still, you are not sure about this thing. The diagnosis yet to be known. So anyway, at that time, there was a very good workup help from the ICMR. Now it's not there. And since the corona, you are not getting any of these encephalitis, any of the lab diagnosis of this so-called encephalitis because there is no time for any of the lab tests to be done now. So thank you, sir.
Okay, I must congratulate Dr. Purushothaman for the excellent conclusion and the tips he has given, because definitely the clues and his practical wisdom has come in this short commentary. Thank you, Purushothaman, for the some newer the insights also into that.
Thanks.
We have two HODs here, Dr. Vijayuma. Dr. Vijayuma. Dr. Shanavasa, Alepi HOD. Okay. Dr. Razia, she is now outside India. Razia, can you hear?
Good evening, sir.
Yeah. I think
it was good. So you have moved out from Hyderabad to Oman?
I'm in Abu Dhabi right now, sir.
Okay, good.
Just few months back. How are you, sir? Excellent talk. Lots of practical.
You continue.
And
Continue
Dr.
your
Purushottam
comments.
has-
Okay.
No, sir, you have almost covered everything, including infectious to autoimmune encephalitis. And Dr. Purushottam has also added lots of practical points. I don't think I can add more than what you have already shared. Thank you for the excellent presentation.
Okay, we'll meet you on July 18th this year.
Yes, sir, sure.
So it was a very wonderful session. We had around 95 delegates. There are so many panel sessions are going on, and we have delegates from Kerala, outside Kerala, and a very good interactive session. So I thank Kunju sir for official vote of thanks. I invite our secretary, Dr. Sidhir Kumar.
Okay, thank you, sir. So this is our 5th episode of Thrissur Talk series, and we have an excellent academic session, and we are very thankful for Kunju sir for coming to IAP Thrissur and giving this wonderful talk. Somebody has put rightly that this talk is very clear and we're covering the basics and very practical. So thank you very much, sir, for this excellent academic session. I also thank AK sir for our Anandakeshavan sir for moderating this session, and I also thank all the IAP office bearers, Johnny sir, Rajagopal sir, and Anju Deepak for the inaugural function, and also thank all the seniors like Purushottam sir, Parvati madam, Vijayama sir, and Shanwa sir for joining us, and also Jose sir from Malapi joining us, and all the delegates for joined us from Kerala and outside. And thank all of you for joining once again, and hope you to see in our next edition of Thrissur Talk series. Will be happening every month on last Thursdays at 8 p.m. So hope you to see you on the next edition, and thank you for joining today, and have a nice day.